Good day, everyone. My name is Kanesh Sivalingam from University of Malaya. I'm one of the consultant urologists here. My topic for today is going to be architecting the standard of care in metastatic hormone-sensitive prostate cancer. So this would be my disclaimer. This is a company-sponsored talk by Dr. Reddy's Laboratories. So just going over the basics, we have the volume differentiation. So that's the high volume and low volume disease as per charted, which is 4 or more bone metastasis with at least one outside the vertebral column, and all visceral metastasis and lymph nodes do not count as visceral mets. And just for everyone's general knowledge, metachronous or relapsed metastatic disease generally carries a better prognosis than synchronous presentation. So, as we all know, standard of care would be continuous androgen deprivation therapy, either in the form of agonists or antagonists, and impending complications such as spinal cord compression, bladder outlet obstruction, or ureteric obstruction. We have a rescue therapy, which is either by surgical castration or using an antagonist. And while taking into their cardiovascular risk profile, and antagonist has a better safety efficacy. And with regards to combination therapy in the setting of metastatic hormone-sensitive prostate cancer, combination therapy is definitely superior to ADT alone. I think that has already been established. And efficacy among the various ARPIs are statistically similar, and the choice of agent must be dictated by the individual's risk profile and toxicity profile. ADT and chemo docetaxel alone is no longer the standard of care when an ARPI is available. And those are the forest plots as shown for the various next generation ARPI and their pivotal trials that they were actually validated. So it is also known that radiotherapy to primary tumor where low volume metastatic disease are present has shown survival benefit, especially as per Stampede, with a hazard ratio of 0.64. Piece 1 has also shown the value of adding radiotherapy with standard of care plus ARPI prolongs the progression-free survival from 4.4 years to 7.5, and also improves on quality of life by delaying castration resistance and drastic reduction in severe GU events such as obstruction, bleeding, urethral obstruction, and channel TURP. So now let's look at some real-world evidence when it comes to role of ARPI in the setting of metastatic hormone-sensitive prostate cancer. So the question that this paper is really trying to answer is not how physicians are treating metastatic hormone-sensitive prostate cancer in real world, but the real thing is how clinicians actually change their practice after years of landmark clinical trials. This is an implementation science paper, not a drug efficacy paper. The authors are not proving that ARPIs work. That has already been established by trials like Chartered, Latitude, Titan, Arches, Enzamed, Peace 1, and Arasens. Instead, they are asking, did physicians believe the evidence enough to change their prescribing behaviors? So out of 3.4 million patients, finally streamlining to 10,717 patients to be included in this cohort. And everyone notices straight that ADT, the usage of ADT alone has decreased. ADT plus ARPI has gained popularity. Triplet therapy has risen in the recent years. But the more interesting observation is evidence changes practices slowly. Clinical trials demonstrated survival benefit years earlier, yet in 2023, as per this paper, 36% of patients still received ADT alone. That lag is a real finding. So most readers conclude, great, physicians are following guidelines. A deeper interpretation is Clinical evidence is necessary but not sufficient to change practice. Real-world medicine is constrained by patient frailty, reimbursement, physician specialty, toxicity concerns, logistics. This paper actually a study of the clinical inertia. So this is a tale of two patients, reality versus current versus what uh, the papers have previously shown. So we have in the combination arm, we have younger group of patients, and they are the de novo metastatic hormone sensitive prostate cancer with bone only metastasis, low comorbidity index, and interestingly, the type of clinician that they are being treated and the type of insurance cover. In the ADT alone candidate, older category of patients with recurrent metastatic hormone-sensitive prostate cancer with high comorbidities, and also the treating clinician as well as the insurance coverage plays a role. And updated guidelines explicitly recommend combination therapy, making ADT monotherapy structurally suboptimal. Who makes up this 36% and why were they excluded? These are categories of older patients with complex chronic conditions, particularly cardiovascular and pulmonary, highlights widespread safety and tolerability concerns with existing combination therapies. Future research and drug development must prioritize tolerability to bridge that 36% of gap that we actually saw in this paper, which was published in 2023. So, my overall critique in this paper, it's a large national data set involving more than 10,000 patients and appropriate focus on real world implementation rather than efficacy, useful description of evolving prescribing patterns. However, the limitations, it's an observational design, cannot establish causation. Claims data lack clinical variables such as performance statuses, PSA, tumor volume, genomic patient preferences. Potential selection bias from requiring continuous insurance enrollment. And there is some industry involvement and several author affiliations that needs to be taken into account before looking into the results. The next one would be another real world data, which is looking at enzalutamide in current modern clinical practice, the AREN-3 study. So again, the authors are not trying to prove enzalutamide works. That has already been proven in randomized phase 3 trials like ARCHES. Instead, they are asking, does enzalutamide still perform well in the messy real world where patients are older, sicker, less selected, and don't fit clinical trial criteria? Their answer is yes. That sounds simple, but there are several subtle scientific messages underneath. So the ARCHES benchmark, there was a 37% risk reduction of death and 37% risk reduction in radiographic progression. Whereas AREN-3, it's a reality check that wants to see if ENZA does maintain its efficacy that was seen in ARCHES. So we have patients with a higher median PSA. We have patients with more bone-only metastasis and higher ECOG statuses with a poorer performance. And the number of low-volume disease patients are also higher. And these are the demographics that were included in AREN-3. And the overall median survival was not reached because the number of events needed were not enough. So hence the median overall survival in AREN-3 was not reached. However, the median time on treatment, a highly durable clinical benefit capturing the reality of patients who maintain treatment before discontinuation, showed at 31.8 months. This would be the efficacy by the metastatic burden. Patients with M1A disease achieve profound extended benefits. Bone and visceral metastasis require careful management of expectations regarding time on treatment. The other important aspect of RN3 would be the early PSA dynamics. So the PSA kinetic has a prognostic effect on this group of patients. That is the PSA suppression to 90% its median time, and the median time to PSA less than zero point 0.2. Achieving a 90% reduction in PSA slashes the hazard ratio for death 0.36. Crucially, 26% of patients achieve this within the first 3 months. While achieving an ultra low PSA is the strongest single predictor for long-term successes, yielding a 96% survival rate at 2 years. While many factors initially matter, age as well as achieving a PSA level of less than zero point 0.2, these two factors would be the independent drivers for survival in the multivariable analysis. And 91% of patients in the study did not have any severe adverse events, and 93% remained on the full dose of enzalutamide. Velocity markers: PSA responses to ENZA occur at moderate predictable speed. Tracking the 6 months and 8.3 months milestone provides a highly accurate, cost-effective window into a patient's long-term trajectory. So, final takeaway protocol for the ENZA management. So, it prescribes across the real-world spectrum, and the monitoring is to track it at 6 months and 8 months, and to stratify by the metastatic burden. So this would be my take-home messages when managing patients with metastatic hormone-sensitive prostate cancer. And with that, I thank you all.